Well, hello, and welcome to our ASNC interview series. This is our episode number 12, and this is an exciting episode. First, let me introduce myself. I'm Ibrahim Saeed. I am currently the medical director of nuclear cardiology at Virginia Heart. Prior to this, I was at St. Luke's Mid-America Heart Institute for about a decade, where I set up a cardiac MRI program, read cardiac CTs, and learned a lot about cardiac PETs. And I'm on the board of directors for ASNC. And I'd like to introduce my colleague, Dr. Kevin Boczar.
Great, thanks, Ibrahim. So my name's Kevin. I'm a participant in the ASNC Leadership Development Program. I completed my clinical training in cardiology and advanced cardiac imaging at the University of Ottawa Heart Institute. And then I completed a second fellowship in advanced imaging at the University of Pennsylvania. Now I'm starting on as a new faculty at the University of Ottawa Heart Institute starting within the next month.
But enough about us. It is now my honor and privilege to present to you and introduce to you someone you already know, Dr. Vasken Dilsizian. He's professor of radiology and medicine at the University of Maryland School of Medicine since 2001. He's the chief of the Division of Nuclear Medicine at the University of Maryland Medical Center in Baltimore since 2007. And prior to that, he spent 13 years at the NIH, where he served as a director of nuclear cardiology from 1992 to 2001. He is a founding member of the American Society of Nuclear Cardiology. He has served on its board of directors and in several capacities, and was awarded the prestigious Master of the American Society of Nuclear Cardiology. In 2016, Dr. Dilsizian was president of the Society of Nuclear Medicine and Molecular Imaging from 2019 to 2020, is a member and contributed to many societies, including the American College of Cardiology and the American Heart Association. And so it is an honor and privilege to introduce him in this series, where we're going to be talking about expanding applications of cardiac PET beyond perfusion assessment, specifically its role in cardiac device infections. So Dr. Dilsizian, welcome.
Well, thank you so much, Ibrahim. Very kind introduction, Kevin. It's always great seeing you. I'm looking forward for our dialogue today on a very important topic, which is identifying native and prosthetic valve endocarditis and cardiac device infections. Just as an introduction, although infective endocarditis is a rare condition, probably the incidence annually is 15 out of 100,000 people. The problem is the mortality of in-house mortality is very high, 20%, with a one-year mortality of about 40%, and long-term outcome, 50% survival at 10 years. Given the mortality numbers that I just gave you, it's very important to have both accurate and timely detection of this disease to improve patient outcome. And so, as you know, even though we're going to be talking about nuclear cardiology today, the number one imaging choice for infective endocarditis is transthoracic and transesophageal echocardiography. And the good news is that it detects the majority of the cases. The bad news is that there are going to be a number of cases where the clinical history is highly suggestive of infective endocarditis, while the echo can be negative or equivocal. This is where advanced imaging, such as FDG PET-CT, can aid both in making diagnosis or even as a complementary information of having extra cardiac information, such as embolic events, or even the nidus or where the infection came from, such as colorectal cancer.
Yeah, this is a very important point, and it's often a diagnostic dilemma, as you're alluding to. So can you just take us from the top through the basics of the image acquisition protocol for an FDG PET study for infective endocarditis?
Yeah, it's a great question. So, the first thing we want to do is we're going to say, if I want to assess inflammatory cells that take up glucose or FDG, I need to suppress the myocardium so that we're able to see macrophages and neutrophils around the valve. And so the way you would do that is you want to suppress the myocardium by first having prolonged fasting. Now, I'm going to not be very strict with my definitions because Obviously, in literature, prolonged fasting can be 24 hours, 12 hours, or more than 4 hours. More importantly, is to avoid carbohydrates. And at least in our institution, we'd like to encourage patients to have ketogenic diet. That would be fatty meals such as eggs, cheese, meat, oil, and anything that can suppress FDG uptake by the myocardium, but not touch the GLUT1 transporters of the neutrophils and macrophages. Once the patient has done that successfully and arrives in your institution or in your laboratory, obviously this is where you would inject FDG, and you need to wait about an hour or so before the FDG is taken up by the neutrophils and distributed throughout the body. This is the point where you would do about 2 minutes CT acquisition and about 20 minutes FDG acquisition. And then the images are acquired in our institution, both for cardiac specific as well as whole body imaging. And you may ask, why do I do that? Well, because as I said, the strength of our technique isn't just to simply identify the valvular infection, but also to identify any embolic events, which can occur, by the way, up to 15% of the patients. And embolics, we've seen a lot in the lungs. Obviously, if you have an embolic event in the brain, it's tough to see because the brain is FDG avid, and it's tough to differentiate an embolic event from the brain tissue. But what we have also found is very important, is the portal entry of the nidus of the infection that caused the valvular infection. Obviously, if you're simply replacing valves but not knowing what the entry port of the infection is, that would be a moot point because the patient is going to be reinfected again. And so a number of times we've made the diagnosis of unknown colorectal cancer that has actually been the cause of the infection of the valve. So I think the technique isn't just superior to identify metabolic before structural damages occur to the valve, which is what most anatomical imaging do very well, is that we are going to see it earlier before structural damage occur, identify the nidus of the infection, and potential prognostic implications of taking care of the patients by knowing where there were embolic events. And I think if you put all of this totality together, it improves patient management decisions and patient outcome.
Vasken, that's very helpful. You kind of alluded to this, with respect to searching for nidus of infection and also embolic complications and whatnot. But can you walk us through, what's your approach for image interpretation in these studies?
Yeah, that's a great question. So, Kevin, as you know, whenever we talk about foreign objects or metallic devices, whether it's prostatic valves, whether we're talking about LVADs or pacemakers, AICD pockets, when you do CT attenuation correction, you are creating hardening artifact that can mimic as if there's an infection there. So one very important approach is that while we are all accustomed of looking at the images in attenuation corrected mode, whenever you see a hot uptake, it is very important to also look at the non-attenuation corrected image to make sure that the site of the infection is reproduced. Now, the type of complication or difficulties or experience that requires in reading these images is that you need to differentiate inflammation from infection. A lot of times, patients may have had surgery recently, within 3 months or even 6 months, and patient may have bacteremia. And the question is this valve infected? Now, even though the European guidelines will say, well, you shouldn't be doing this within 3 or 6 months of surgery because you're still going to have inflammatory cells there. But clinically speaking, this is an important decision-making point. So I humbly disagree with the general recommendation. Yes, we do see inflammation, but if the patient needs an imaging study, we would definitely do an FDG PET CT. And this is where the expertise of the interpreter comes in, right? Mm-hmm. Inflammation is usually homogeneous uptake, not heterogeneous, lumpy, bumpy, hot, paravalvular abscess uptake, right? And that comes with experience. I think that once you get that under your belt, and once you start seeing also just regular grafts in the rest of the body, where you've seen just elongated kind of rail track like long homogeneous uptake, you realize that's just inflammation, that's not infection. Obviously, we make a difference between a large vessel infection from prosthetic grafts infections. So the bottom line, Kevin, is that you need to look at the attenuation and non-attenuation corrected images. And you need to know the difference between inflammation and infection. Now, there are some bioadhesives that are used in certain valves that will have very hot uptake. And that is very characteristic. Again, you need to know that. You probably know that from the surgery, what kind of valve was used, what kind of bioadhesives were used. That's where the specificity comes in. So my recommendation is when you're starting a lab early, there's a lot to learn. You have to be humble and curious. You have to make sure that you learn and attend a lot of these case-based conferences that multiple societies are offering. And I think with time, you will be able to differentiate all of these potential artifacts that may appear. And worst scenario is that sometimes, as you know, the surgeons will walk in and say, no, my valve that I put in is definitely not infected, while the infectious disease teams will come down and say, yep, I think this is infection. So if there's such debate and you're in the middle of this, obviously, it is recommended that you would do WBC imaging, which has a higher specificity, but lower sensitivity.
You know, you already answered a lot of the questions I was going to bring up next, was just some of the confounders of image acquisition. You've mentioned attenuation versus non-attenuation corrected imaging. You've mentioned the differences between inflammation and infection. You've talked a little bit about the bioadhesives. Are there any other confounders that we should be aware of? And the second part of my question would be, some of the newer digital PET CTs are very sensitive. Yeah. And if you could just speak on that.
Sure. Well, I mean, regarding camera advancements, Ibrahim, I mean, I think you probably know, most of the new cameras of PET CT are digital. The days of the analogs, I mean, those are just are almost gone. So clearly, we are moving into the advanced technology now, higher sensitivity, higher comp rate. The advantage, obviously, is you can give half the dose or half the time. I think that we are grateful for our physicists and engineers who are moving forward in hand with us, providing us really high quality technology, including whole body imaging, as you know, with PET CT, which makes it much easier. What I just alluded to earlier, when I said, why just stop at cardiac, why not at whole body? I mean, think about it. If you have a whole body PET CT digital, you can do this in a couple of minutes. So you're not really wasting time. You're getting the total information. I think we're moving in that direction. So I'm grateful for our industry partners that are kind of investing in our field, if you will, and realizing that this is the future, and it's a very important field of molecular imaging. The other part I wanted to point out is this patient management question. We keep talking about diagnostic accuracy, which is important. We always think about imaging and diagnostic accuracy, but what we don't talk much about is, can we use imaging for patient management decisions and patient outcome? What do I mean by that? So if I image a patient and I treat them with antibiotics, and now the subsequent imaging is completely normal, should I then recommend extraction of the device? Can we use our imaging criteria to say, continue antibiotic treatment and do not go to extraction of the device? In contrast, patients who are on antibiotics and there's no significant improvement in the signal, or there's minimal improvement, or now you have embolic events, obviously that's a completely different situation. So I think that we spend too much time of focusing on which technique is more sensitive, more specific, more accurate. That's important as an entrance to the field, but I think that our signal is far more important than just that. And I'm hoping that there are, by the way, a few papers talking about patient management decisions and outcome in negative FDG. For example, if you have a vegetation that's seen on echo, that's not infected. Yeah. Now, right now, you would read FDG PET-CT, you say, well, it missed it. I see a vegetation there. But we haven't really said, is that vegetation truly infectious or not? Maybe PET-CT is correct. Maybe if we follow that PET-CT, we'll get the answer. So I think there's more to learn from this, Ibrahim and Kevin. I think that it was just starting. And most of the literature right now are unfortunately retrospective data, case reports. And that's why the guidelines haven't really made a firm recommendation, except for the prosthetic valve endocarditis with the European Society of Cardiology. But I feel that it's tough to do a randomized trial. We're going to have to rely on expert opinions like we are here. I think that we have to accumulate our knowledge base and make best recommendations accordingly.
Vasken, in terms of pulling all of the things that we've already talked about into your final interpretation, are there any additional things that you would comment on, whether it be, intensity of the SPV values or anything else that you pull into your final interpretation? And how do you recommend the clinician consumer of your report use those results clinically?
That's great, Kevin. I'm glad you brought up the SUV issue. I mean, it's a hot topic, right? I mean, everybody would like to quantify. We're in the world where we think that if we have a number, it's objective and therefore it must be correct. Whereas, if you spend a lot of time and you guys have looking at FDG images, whole body, you see that you can have a infectious site that can have a high SUV. You can have malignant sites that can have relatively low SUV. So SUV itself, although is good, let's say in lymphoma patients, to monitor chemotherapy and follow whether there's decline in the size and intensity of the uptake in lymph nodes. I think that predicts patient outcome. I think that that's very good. But in the case of diagnosis, I find it not very helpful to say a site has an SUV 2.5 or 4.5, and therefore that's infection versus inflammation. I find the pattern of the FDG uptake a lot more useful than the SUV. Now, some will disagree with me, but I can tell you that there's a lot more going to the SUV, as you know, even the weight calculation, besides the injected dose. So it's not a perfect measure, but it's a good guideline. I think I do report the number, but I don't use that as a guideline to say it's infection or inflammation. And as I said to you, regarding clinical patient management, we started our experience following the early work with pacemaker implantations. We're doing the pocket infections, and we gained the trust of our referring physicians, EP, cardiologists, and then it moved to the heart failure and heart transplant specialists, where they came to us with frustration with their LVAD patients. And then I proposed to them, why don't we do LVAD imaging? We're probably one of the first in the world to be doing this in a series of patients, early and post, which we published in JACC Imaging. And we found out, as you know, that if the infection is limited to the periphery, that is the exit wound or driveline, versus centrally, cannula or pump, it makes a big difference, both in patient management, antibiotics, right? Or early placing the patients to the transplant list if it's a central infection. And so it became, again, it wasn't a yes or a no. Yes, it's an infection. I'm saying it's an infection. Is it periphery versus central? If it's periphery, antibiotics. Central, we should move up to the transplant list. So all of these have made a clinical major impact on patient outcome. And that's why I feel very strongly that we are in a wonderful field, that our colleagues in cardiologists and infectious disease surgeons are appreciating it. And I think we're just starting, just scratching the surface of what we're going to be able to do with metabolic and molecular imaging.
I think we are just scratching the surface of all the questions we want to ask you as well, too, when it comes to this topic. So you've brought up a lot of important points. Some are about image interpretation and how we just need to get in there and have experience. A lot of it, I think, also has to do with patient preparation. So how do you prepare differently for infectious imaging, sarcoid imaging, inflammatory imaging, viability? What differences in prep do you have, and dietary prep for
it's a great question. As you know, my career began in viability, and I'm a fan of viability. And the critical component of viability is the preparation of the patient, which is exactly the opposite of what I just said. Instead of suppressing the myocardium because preferentially uses fatty acid, we wanted to encourage glucose utilization, FDG uptake. So in those patients, I was rather surprised when I had a debate with a colleague of mine in one of the ASNC meetings, where he pointed out to me that about 50% of his patients had poor dietary preparation or poor image quality for viability because of the difficulty of the insulin protocol and diet. And I was kind of shocked because in our institution, over 95% of the studies are simply superb and absolutely right on. And I think that, so it's not a matter of community or academia. It's a matter of understanding that while protocols are guidelines, a lot of times you have to use common sense in deciding how much insulin to give, when to give, and what is the rate of decrease of glucose that you want to see from 300 to 150 versus 300 to 250. And all those decisions will make a difference in image quality. So as to your question about infection, obviously in sarcoid, it's exactly the opposite. In sarcoidosis, it's the same things, inflammatory cells rather than myocytes. So you want to suppress the myocyte and you want to encourage visualization of the inflammatory cells. So the preparation for sarcoid is no different than what we do for infection imaging.
Finally, Vasken, do you have any advice for nuclear cardiology labs that are just ramping up or starting their FDG imaging for infective endocarditis?
Yeah, well, as I said earlier, Kevin, I think that the best part of our technology or the field is that we are changing and we're evolving. As I said, I trained at the time when we were transitioning from planar to SPECT, and people were very worried about transitioning to SPECT. And now we're in the era of transitioning from SPECT to PET. And as you know, a lot of people are nervous or feel very comfortable with their SPECT technology. But PET is opening up entirely new opportunities for cardiac imaging. And as you know, with sarcoid, and there's going to be new PET amyloid radio tracers that's already being published. And we can use FDG for infection imaging, sarcoid imaging, viability. So beyond perfusion, now we're entering the era of the molecular imaging. So my recommendation for those who are starting is be curious, be open-minded, and attend a number of these webinars, seminars, in-person meetings, ask questions, learn from the case examples, and don't be shy to ask a colleague. Pick up the phone and say, I have such and such case. What are you thinking based on your experience? I think we're a very small community and very supportive community. And I think that we should be able to help each other and the next generation be good mentors. And so we develop this technology and move forward to the next phase. And I think that not only we're moved to PET-CT, now we're talking about whole body PET-CT, where we can be able to look at the simultaneous physiology and dynamics, the interrelationship between kidneys, the heart, the liver, and the brain. And that's where we're moving. And it's really fun.
Well, our time has run out, and I wish we could go on forever. But this was an exciting conference with Professor Vasken Dilsizian on how to expand cardiac PET beyond perfusion assessment, specifically its role in cardiac device infection. Lovely takeaways. The one that I take personally is be curious, be open-minded, and dive in.
So Ibrahim and Kevin, and this was fantastic. I appreciated the opportunity to talk about something that I'm excited about, and I hope we take this field to the next step. And hopefully we'll be talking about other opportunities of molecular tracers that are in the basic science lab right now, that hopefully will be in vivo biochemistry form very soon.